focal and diffuse proliferative glomerulonephritis. You can eliminate this entity from your curriculum. Next, very importantly, IgA nephropathy. IgA nephropathy. IgA nephropathy. And one of the chronic important causes, chronic glomerulonephritis. These are all primary causes. Apart from them, there are some secondary causes, multi-system organ involvement. It can involve, as a very important entity, diagnostic criteria for SLE, systemic lupus erythematosus. Systemic, that means it not only involves the kidney, but also involves the bone, lung, blood, cardiac, skin, brain, etc. All involvement. Of course, diabetic nephropathy, second entity, very major entity, diabetic nephropathy. Third, amyloidosis, deposition disease, amyloid deposition in glomeruli. Fourth, and rest of the features are different entities of vasculitis. I will take a separate class of vasculitis. It's a very tough topic. আমি বলেছি কি রাকেশের সাথে বোধহয় কথা হয়েছিল. I will take a separate class on vasculitis. So which are that vasculitis which primarily, secondarily involve glomerular disease? These are polyarteritis nodosa, Wegener's granulomatosis, good posture syndrome, that is known as anti-GBM disease, Chelation purpura, and cryoglobulinemia, idiopathic mixed cryoglobulinemia. And lastly, some systemic involvement, systemic infectious involvement, যার মধ্যে ব্যাকটেরিয়ার মধ্যে খুব ইম্পর্টেন্ট তোমাদের জানতে হবে সাবঅ্যাকিউট ব্যাকটেরিয়াল এন্ডোকার্ডাইটিস, অ্যান্ড ভাইরালের মধ্যে জানতে হবে HIV, hepatitis B, hepatitis C. So these entities are very important. Secondarily আমি কি বললাম, lupus nephritis comes to your clinic, they will come you with some clinical features, and these clinical entities can be differentiated into six major group or six major group of syndromes. One syndrome is known as nephritic, second is nephrotic, third is acute renal failure, fourth is chronic renal failure, fifth is asymptomatic proteinuria, and sixth is asymptomatic hematuria or painless hematuria. প্রত্যেকটা এন্টিটি আমি আসছি, but before that you have to know what are the major causes of nephritic and nephrotic syndrome. These two syndromic approach is very important for glomerulonephritis because most of the cases of glomerulonephritis comes with clinical features of either nephritic syndrome or nephrotic syndrome. আমি বলছি পরে কি কি what are the clinical features of nephritic and nephrotic syndrome, but before that we have to have a good idea about which disease comes as nephritic syndrome presentation, which are the disease which comes with nephrotic syndrome presentation. In nephritic, acute nephritic syndrome presentation, যেটা আমি বাঁদিকে লিখেছি, these entities comes with nephritic syndrome. One is post-streptococcal glomerulonephritis, rapidly progressing glomerulonephritis, IgA nephropathy, and membranous proliferative. These four entities included in nephritic syndrome group. And secondary causes of glomerulonephritis which comes after nephritic syndrome could be SLE, could be some vasculitis like Wegener's granulomatosis, Chelation purpura, PSA, or cryoglobulinemia. Next, coming to the nephrotic syndrome presentation. It's not working actually. Primarily, if I am talking the nephrotic syndrome and the primary glomerular disease, most importantly, the most common causes of nephrotic syndrome in case of childhood is minimal change disease. This is a short, actually MCQ question. and usually the minimal change disease, the mainstay of treatment of nephrotic syndrome is steroid in case of child. But good amount of cases, about 30% of all cases, they are steroid resistant. And whenever we do some biopsy, guided biopsy from steroid resistant cases of nephrotic syndrome, they are usually, in case of child, they are usually focal segmental glomerulonephritis. Focal segmental glomerulonephritis, which actually the most common causes of adult nephrotic syndrome. Adult nephrotic syndrome. Third, membranous glomerulopathy, and of course, another cases may present with nephrotic syndrome. ঠিক আছে, বুঝেছো? এছাড়া কি, what are the secondary causes? Systemic causes এর মধ্যে diabetes mellitus usually present with nephrotic syndrome, amyloidosis, and except 1, 2, 3, 4, all the stages of, there are 5 stages, actually 6 stages, 6 stages of lupus nephritis. Apart within of all 6 stages, only the stage 5 of lupus nephritis presents you with nephrotic syndrome. Some systemic infection like viral infection, bacterial, protozoal, etc. Few drugs causes nephrotic, and few malignancy, most importantly, very important point, Hodgkin lymphoma, carcinoma, and myeloma, they present as nephrotic syndrome. So, what are the presenting symptoms of any kind of renal diseases? Mostly the glomerular disease. There might be some proteinuria. When I am talking about proteinuria, you should have a very good idea what is known as proteinuria. Presence of albumin in urine usually normal, but up to a certain range, it is around 25 to 150 milligram per 24 hours. But when this albumin is exceedingly presenting in urine more than 3.5 gram per day, 3.5 gram per day, that is only the albumin, this is known as selective proteinuria. কি বলে? Selective proteinuria. Selective proteinuria more than 3.5 gram per day is a feature of nephrotic syndrome. Is a features of nephrotic syndrome. কথাটা সারা জীবন মনে রাখবেন। Albumin is a very low molecular weight protein. Apart from albumin, there are so many proteins in blood like globulin, transferrin, thyretin, etc. These are known as high molecular weight protein. If there is presence of high molecular weight protein, but the range is less than 3.5 gram per day, known as non-selective proteinuria. That is presence of high molecular weight protein less than 3.5 gram per day in urine is a feature of non-selective proteinuria, and nephritic syndrome is associated with non-selective proteinuria. দুটো পয়েন্ট বললাম, ক্লিয়ারলি মাথায় রাখবে, সারা জীবন এই দুটো নিয়ে তোমাদেরকে ডিল করতে হবে, সারা জীবন এই দুটো পয়েন্ট নিয়ে, selective proteinuria of nephrotic range, non-selective proteinuria of nephritic range. Okay, so one of the clinical features presenting symptom is proteinuria. Second is anuria or oliguria. Oliguria means less than 500 ml of urination in day is oliguria, and oliguria is a feature of nephritic syndrome. Nephritic syndrome. Okay. More than 4.5 liter per day urination is known as polyuria. There are so many causes of polyuria, like excessive fluid in the body, diabetes insipidus, diabetes mellitus. But when I'm talking the polyuria in context of glomerular disease, it's known as nephrotic syndrome. Polyuria is a feature of nephrotic syndrome. Okay. Next, Chelation, hematuria. Presence of frank RBC is known as hematuria, but there is a terminology known as microscopic hematuria. Microscopic hematuria means no RBC in urine at gross. The urine looks like almost clear or just turbid, but presence of more than 5 crenated RBC or RBC cast, that is either more than 5 crenated RBC or RBC cast in urine, is a feature of microscopic hematuria. Microscopic hematuria. So if it is a gross hematuria, usually the urine looks like cola color, smoky urine. But in case of microscopic hematuria, the urine will look like just turbid one. And both these two features are important features of nephritic syndrome. Mone thakbe? Okay. Next, some cast. Urine তোমাদের ডিওপি তে আমি এখনো নিইনি, আমি নেব প্রত্যেকটা ব্যাচেরই আমি অ্যাজ সাচ আমি এবার ডিওপি তোমাদের সবাইকে বলে রাখি যে কোনো একটা পার্টিকুলার ব্যাচের জন্য হবেই, অফকোর্স যখন তোমাকে স্লাইড দেখাতে হবে এতগুলো স্টুডেন্টস আছে আলাদা আলাদা করে পার্টিকুলার ব্যাচের জন্য হবে, বাট ইফ ইট ইজ আ থিওরি ক্লাস I will cover up in lecture theatre and that will be taken as whole for whole class, for A, for B and for C. Okay. So তোমাদের ইউরিনের মনে রাখবে আমি একটা ইউরিনের ফুল ইউরিন এক্সামিনেশনের একটা ক্লাস নেব, that will be a item card for you for your exam. So urine কিছু কাস্ট পাওয়া যায়, কাস্ট are nothing but coagulated proteins with which some entities are present. That could be hyaline cast or granular cast, যার মধ্যে কি থাকবে ডিগ্রেডেড গ্লোমেরুলাই থাকতে পারে or necrotic cell থাকতে পারে. That could be a RBC cast, that means the RBC is a content. WBC cast in case of chronic pyelonephritis, WBC cast can be found. That would be a broad cast. The whole glomeruli is reflected by presence of a very huge degenerated cellular cast, usually found in chronic end-stage renal disease. That could be a waxy cast. Any kind of cast might present either in nephrotic or nephritic, but except the RBC cast are usually seen in case of nephritic syndrome. And waxy cast, that means there will be presence of fat within the cast. That waxy cast, presence of waxy cast are important features of nephrotic syndrome because nephrotic syndrome usually present with three another features. One is hyperlipidemia, that is presence of high cholesterol, total cholesterol, LDL cholesterol, except HDL cholesterol, other entities are high. And lipiduria, presence of lipid in urine in form of waxy cast. Okay. বোঝা গেল? And two important features of nephritic syndrome. One is hypertension. Why hypertension is occurring in nephritic syndrome? Exactly. There will be total damage of what? Glomeruli. Not a partial damage, total damage. So there will be more activation of what? Juxtaglomerular apparatus. So that causes the activation of renin-angiotensin system and more sodium, potassium absorption, retention within the body. So that will cause hypertension and edema. But this edema is due to more sodium potassium retention. But edema, when it is periorbital, what are the dependent part of the body? And it is due to, secondary to, loss of huge amount of albumin. That causes the decrease in the oncotic pressure. That edema is a feature of nephrotic syndrome. Okay? So, hypertension is a feature of primarily nephritic syndrome, but periorbital diffuse edema is a feature of nephrotic syndrome. Okay? It's not working. And of course, it's both the causes, nephrotic and nephritic syndrome, ultimately going to stage of renal failure. So, whenever there is renal failure, the filtration is not okay. So, different excretory product in the body will be high. So, that will cause retention of the nitrogenous end products like urea, creatine, etc., known as azotemia. And whenever there is huge amount of the excretory product within the body, that will cause encephalopathy, renal failure, and different features of renal failure like pigmentation, pruritus, fatigue, etc., etc. So these are all presenting symptoms of glomerulonephritis. See, these are main features of nephritic and nephrotic syndrome. Nephrotic syndrome usually present with polyuria, selective proteinuria more than 3.5 gram per day, edema secondary to hypoalbuminemia, hyperlipidemia, lipiduria, and presence of different protein cast. Okay, protein cast. Most, and also of course waxy cast. Waxy cast. But if it is a nephritic syndrome, the presenting features will be like oliguria, hematuria, non-selective proteinuria. Usually the nephritic syndrome present with the end-stage renal disease, so there will be azotemia, renal failure, features of renal failure, edema, that will be secondary to sodium water retention in the body, of course hypertension, and RBC cast, that is microscopic hematuria, or cola color urine, that is macroscopic hematuria. Okay, so these are the clinical symptoms, and you have to deal these two things. All these entities will be dealt under mainly these two headings, nephritic and nephrotic. What are the disease presented with nephritic syndrome? What are the disease presented with nephrotic syndrome? What are the disease presented with asymptomatic hematuria? What are the disease present with asymptomatic proteinuria? ঠিক আছে, এটুকু বুঝেছো? ওকে, ইটস আ ভেরি বেসিক পয়েন্ট, আমি এখনো প্যাথোলজিতে ঢুকিনি। সো প্যাথোলজিতে যদি ঢুকি, কি করি আমরা, কিভাবে দেখি কোনো কিডনি বায়োপসি? Usually by 3 modes. We interpreted any kind of kidney biopsy by 3 modes. How can I take the kidney biopsy? It's a guided core needle true cut biopsy. Guided core needle true cut biopsy. Guided by either USG guidance or by CT guidance. Okay, and this is a core needle biopsy. Usually 16 to 18 gauge needle are used for taking out the core of, তোমাদের দেখাবো, তোমাদের এটা একটা স্লাইড আমি দেখাবো গ্লোমেরুলোনেফ্রাইটিসের যে এন্টিটি গুলো যে কটা আছে, আমি একটা যেটা পারবো আমি দেখাবো। Usually we do initially, for any histopathology we do initial HA staining. Apart from 2 special stain we have to do for seeing some important structures. One is PAS stain, one is silver methamine stain. Okay, another section is taken. That section is used for immunofluorescence staining, direct immunofluorescence staining. কি দেখে immunofluorescence? It will only see the deposition of immunocomplex within the glomeruli. We will see whether this deposition is linear or granular. That means the site of deposition. One, deposition এর site দেখতে গেলে আমাকে particularly কোনো fluorochrome use করতে হবে, and that fluorochrome will be used against a particular antibody or complement, because when there is immunocomplex deposition as a disease entity, that will bind, that comprises some antigen, of course that there is, and some antibody. That antibody could be of two types. One, some immunoglobulins and complement. So these immunocomplexes can be interpreted under three headings. The pattern of immunoglobulin deposition, আসছি আমি. Second, type of antibodies used. Either it is if it is an immunoglobulin, then whether it is IgM type, IgG or IgA type, or it is a complement type. That complement মানে কি, end product কি হবে, either that is classical pathway complement or alternative pathway complement. Classical means C4, C4-1, C2, etc. If it is alternative pathway, and C3 is a very common pathway, and if it is and C1q, of course C1q, but it is an alternative pathway, then propardine, exactly propardine. So we have to see these antibodies in immunocomplex and the intensity of staining. I bolchi they are graded in grade 1, 2, 3, 4, 5, etc. 1 to 4, 1 plus, 2 plus, 3 4 plus, 3 plus, 4 plus, etc. And third entity, third important, আমি দেখিনি, আমি পিজিতে ছিল না, আর আমি আমার টাটাতেও ছিল না, সেটা হচ্ছে স্ক্যানিং ইলেকট্রন মাইক্রোস্কোপি. The ultrastructure of the globuli, ultrastructure of the pathology can be seen with the scanning electron microscopy. Bowman's capsule, yes, okay, Bowman's capsule. Podocyte, yes, and again another some other things. Basement membrane, yes, of course, basement membrane of what? That could be capillary, okay, that is for capillary. Other than that, endothelial cell. তাহলে কি হচ্ছে? There is an afferent artery. Afferent artery, it's an end artery going into nephron. They produce a tuft known as glomerular capillary, and they are projected out as a efferent artery. These glomerular capillary are supported by some matrix. This matrix contain collagen product and some other proteinaceous and fibrocollagenous product. The glomerular capillaries are, এই কথাটা ডিলিট করে দেবেন, কিছু বলে ফেলেছি, আমি প্রচন্ড অভদ্র লোক, প্রচন্ড. The glomerular capillaries are, that is the tufts are supported by some matrix that contains the collagen product, proteinaceous background, and it forms a parenchyma. It's known as mesangium, and within the mesangium there will be some important cells known as mesangial cells. So first glomerular means key capillary plus mesangium. Third, surrounding the capillaries, that is surrounding the basement membrane of capillary, they are encroached by some food processes of particular cell known as visceral epithelial cell. Another name of visceral epithelial cell is what? Podocyte. And these podocytes grab this capillary lumen by what? By some fenestrated food capillaries, food processes. So third is podocyte or visceral epithelium. Then there will be some gap, and that will be bounded by some capsule, and that will be lined by parietal epithelium. Exactly, parietal epithelium. These four entity forms ultimately the glomeruli. See, this is a very diagrammatic, so this is the capillary lumen. Try to understand. This is the capillary lumen. Okay. The capillary lumen endothelium is fenestrated. There will be fenestration, there will be gap between the capillary lumen. And outside the capillary lumen, there is a membrane known as basement membrane, glomerular basement membrane, red color. These reddish area are glomerular basement membrane. Okay. These basement membrane are capped by or grabbed by some podocytes. These are podocytes. Okay. Makushar moton lagche. And they have some food processes. In between, these food processes have fenestration. Between the food processes, there are so many gaps known as fenestration. Okay. And outside, there is a clear space known as Bowman space, and that will be capped by parietal epithelium. So, ki hocche? Within the capillary lumen, there is blood. They are lined by endothelial cells, single layer of fenestrated endothelium. They have a slit-like process. The ultrafiltrate from the blood go across the basement membrane into the fenestration of parietal epithelium or podocyte, and ultimately that podocyte control which kind of elements go across this pathway, and ultimately যখন সে রিলিজ করলো প্রোডাক্ট গুলোকে, they form ultimately the urine. This Bowman space is nothing but urine, and it is lined by inside visceral epithelium and outside parietal epithelium. বুঝানো গেল? বুঝেছো জিনিসটা? খুব ইজি. Now we have to identify different deposition of what? Immunocomplex. According to the site of deposition, that could be subepithelial deposit, mesangial deposit, or subendothelial deposit. Mesangial deposit means this is the mesangium. Okay, the capillaries are supported by some matrix, and within the matrix there are some important cells known as mesangial cells. They have a nuclei. The capillary endothelium cell have a nuclei also. They all have a nuclei. Mind it. So if the glomeruli, the depositing within the mesangium, it is known as mesangial deposit. If it deposits between the endothelium and the basement membrane, subendothelial. And if it deposits between the basement membrane and parietal epithelium, that is podocyte, subepithelial. All kind of immunocomplex deposits are described under these three headings. ঠিক আছে? মনে থাকবে? এইটুকু কনসেপ্ট নিয়েছো? এবার মেইন কেমন দেখতে লাগে আমরা দেখি। So this is the anatomy of kidney. Importantly, see this area. We all know these are known as renal papillae. The importance of renal papillae is this is the primary site of involvement of some important disease entity. One is diabetic nephropathy, where there is necrosis of renal papillae can be seen. Another, cocaine, HIV infection, analgesic use. They all present with renal papillary necrosis. মনে থাকবে? ওকে। কাজ করছে না, আমাকে লিখে দিও। নর্মাল, দিস ইজ হিস্টোলজি। আর নর্মাল এইচপি স্টেনে কেমন লাগে? সি একটু চেষ্টা করো বোঝার। দিস আর টাফটেড প্যাটার্ন, বুঝতে পারছো? Capillaries are seen in a tufted pattern. Small open open lumen can be seen. Open whitish lumen can be seen, and they are bounded by some basement membrane. These are capillary lumens. These are all capillary lumens. Okay. In between the lumen, see, there is a lumen, there is a lumen. In between the lumen, there is a matrix known as mesangium. Within the matrix, there is some cellular outline. The nuclei can be appreciated here, 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 here. Nuclei can be appreciated. These are mesangial cells. The basement membrane of capillary lumen in outside area are grabbed by some cell, and they have a nuclei like this, like this, like this. These are nothing but podocyte. This clear space between podocyte and this visceral epithelium, that is, sorry, parietal epithelium, is known as Bowman space. And see, these cells are nothing but parietal epithelium. This is nothing but a glomeruli under histopathology. But the problem is, we cannot appreciate the basement membrane or mesangium from this HS10 only. That can be appreciated with this stain, PAS, paracetic acid skip. তোমাদের স্পেশাল স্টেনের উপর ক্লাস হয়েছে কিছু? হয়েছে? আরে হ্যাঁ না বলো। Paracetic acid skip is a very good reagent to stain the basement membrane only. See, these are basement membrane can be clearly, you can appreciate the basement membrane of capillary. In between the basement membrane, you can appreciate the mesangium, and they are graphed by some podocytes, and outside the Bowman's space, some parietal cells are there. Next, and ultrastructure can be seen with scanning electron microscopy. From outside, these are nothing but the podocytes, and these are fenestrated endothelium. The podocytes are capturing the fenestrated endothelium. From inside, these are fenestrations, and these are food processes of the podocytes. Oh, next. So, এটা আমি ultimately বলছিলাম, this is the filtration unit known as filtration unit. Filtration units are ultimately composed of what? One is fenestrated endothelium, plus basement membrane, glomerular basement membrane of capillary, GBM, glomerular basement membrane of capillary, and food processes of what? Podocyte. Food processes of podocyte. This is the filtration unit. See, ultrastructure of filtration unit. This is the glomerular capillary. Beautiful. They are lined by fenestrated endothelium. In between the food processes of podocyte, this structure is known as basal lamina. Basal lamina of what? Glomerular basement membrane. And these are tapered. Small cells are known as food processes of podocyte, and in between the food processes there is fenestrations, and in between the podocytes and parietal epithelium there is a clear space known as Bowman space. Next, so main pathology now. এবার ঢুকলাম প্যাথোলজিতে। What are the causes of glomerulonephritis? What are the basic problem of glomerulonephritis? The basic problem is that can be differentiated into two types. Basically কি হচ্ছে, এই যে বললাম glomerular filtration membrane that has been damaged to some secondary causes. Either there might be some immunological causes. The causes can be differentiated into either immunological cause or non-immunological cause. Immunological causes can be differentiated into Four, mainly not four, and mainly three causes. One is formation of immunocomplex. Second is activation of complement pathway. Complement pathway. And third is autoimmunity. That means there will be either excessive production of a particular group of immunoglobulin or some autoantibodies already present in the body. তোমরা ইমিউনিটি পড়েছো, অটো অ্যান্টিবডি পড়েছো। অটো অ্যান্টিবডি কি করে? মলিকুলার মিমিক্রি করে। বডিতে যখনই কোনো সিমিলার কাইন্ড অফ অ্যান্টিজেনিক এপিটোপের সঙ্গে দেখা হয়, তার সঙ্গে জুড়ে বসে যায়। ভীষণ রোম্যান্টিক আর কি, ওরা ভীষণ রোম্যান্টিক। তো অটো অ্যান্টিবডি কি করবে? These autoantibodies actually reacts with different antigens present in glomeruli. Anti-nuclear antibody is ANCA. ANCA is one of the important autoantibody which cross-reacts with different antigens present in glomerular basement membrane or alveolar basement membrane present in lung. So most of the cases ANCA positive যখনই কোনো vasculitis দেখতে পাবে, two structures are primarily involved. One is kidney, one is lung. সে ওয়েগনাস গ্রানুলোমাটোসিস হোক, ক্রায়োগ্লোমেরুলিনিয়া হোক, পলিঅ্যাঞ্জাইটিস নোডোসা, HSP হোক, etc. ANCA positive, C ANCA positive, or that could be P ANCA positive, different type of ANCA positive cells, they cross react with. So this is known as autoimmunity. Autoimmunity. So these three mechanisms are most important for immunological causes. Immunological causes. Now, immunocomplex production could be of mainly two types. That could be what? Generalized. That could be localized. আগে localized বলিনি, একটা ডিজিজ আছে কি বলেছিলাম, membranous nephropathy. Membranous nephropathy. In membranous nephropathy, the immunocomplex are produced against the phospholipase A2 receptor, and these immunocomplex are deposited along the basement membrane, linear fashion, or that could be deposited in mesangium or in the subendothelial space. They form as spikes when they deposit in the subendothelial space. So it's an example of localized immunocomplex deposition. And that could be a generalized immunocomplex like post-streptococcal glomerulonephritis. কোন একটা অ্যান্টিবডি যেটা রিঅ্যাক্ট করছে কার সাথে? Streptococcus antigen সঙ্গে, but that streptococcus antigen having a particular epitope which have some similarity with either podocytes, or that could be a skin antigen present in the basement membrane of epidermis. So that molecular mimicry causes ultimately the huge amount of complex immunocomplex formation. This immunocomplex actually passes through the blood and they deposited in a secondary site. In post-streptococcal glomerulonephritis, they deposited in what? In glomeruli. So there is an hypersensitivity reaction that could be type 2 mostly, or that could be type 3. So this is the funda of generalized immunocomplex. So what are the disease? Post-streptococcal glomerulonephritis, focal segmental glomerulonephritis, or rapidly progressive glomerulonephritis, different infectious causes, infectious, post-infectious, acute nephritic syndrome. And another is anti-GBM, আর একটা বলতে ভুলে গেছি, anti-GBM disease. In case of good posture syndrome, good posture syndrome কি হচ্ছে antibodies are reacting against the antigen present in the glomerular basement membrane and this deposition in the basement membrane কি হবে তো পুরোটাই তো linear হবে that deposition will be a linear type of deposition so anti-GBM disease আর complement mediated pathway আমি পরে আসবো there is an entity known as C3 nephropathy dense disease which is usually seen in case of type 2 membranoproliferative glomerulonephritis where the alternate pathway is activated one important example another example সব আসবো সব একটা একটা করে আসবো another example is IgA nephropathy complement pathway activation alternate complement pathway activation is seen so these as all the immunological causes of glomerulonephritis and some non-immunological just তোমরা বুঝতেই পারবে in diabetes glycosylated products are depositing within the glomeruli in amyloidosis amyloids are depositing in the glomeruli etc infectious causes there will be direct injury of glomeruli in case of HIV hepatitis B hepatitis C etc or some drugs causing the direct deposit or in case of hypertension there will be or rapidly progressing glomerulonephritis there will be parietal epithelial damage so basically this is the pathogenesis when there is complete damage that will present as nephritic syndrome there is partial damage presents as nephrotic syndrome see this is the যেটা বলছিলাম ডিফিউজ ডাইরেক্ট ইমিউনোফ্লোরেসেন্স এইরকম লাগে জানো দেখতে আরো পরে ছবি আছে দেখাবো they have a very dark background and immunocomplex are depositing along the capillary wall or subendothelial or subepithelial কোন সাইট সেটা তুমি usually you cannot appreciate in the direct immunofluorescence the only it can be appreciated in the scanning electron microscopy the site of immunocomplex deposition can be appreciated in the scanning electron microscopy only you can appreciate there is presence of immunocomplex if it is a linear then the intensity will be same throughout the glomeruli so actually the deposition can be described in two terminology that could be linear deposit that could be granular deposit if it is an immunocomplex and it is depositing a particular portion of a glomeruli like subendothelial subepithelial mesangial they produce a granular type of deposit but when this deposit is along the whole all basement membrane of glomeruli that will be linear deposit like anti-GBM disease and intensity কি বলেছিলাম যদি পার্টিকুলার ডিপোজিটের ইন্টেন্সিটি হাই হয় they are graded as 4 plus or 5 plus etc so they stain with a particular stain either immunoglobulin IgM IgG IgA or complement usually C3 C1q C3 C1q দিয়ে স্টেন করা হয় so যেটা বলছিলাম these are clinical features of glomerulonephritis asymptomatic proteinuria painless maturia nephritic syndrome nephrotic syndrome and renal failure end stage renal failure we also describe poretta এই যে poretta we also describe the morphology of glomerulonephritis in 4 important terminology এই terminology one is focal one is global one is segmental দেখো minutely ব্যাপারটা শোনো, when all glomeruli involved known as diffuse type of involvement. All glomeruli involve a particular section is a diffuse type of involvement. But when less than 50% glomeruli involved known as focal involvement. Less than 50% glomeruli involved known as focal involvement. Okay. When the whole area of a particular glomeruli involved, known as global involvement, whole area involved, known as global involvement. And when less than 50% area of a particular glomeruli involved, known as segmental involvement. চারটে পয়েন্ট, চারটে খুব কাছাকাছি টার্মিনোলজি, বুঝেছো? তাহলে বলো ফোকাল সেগমেন্টাল বলতে কি বোঝায়? of all glomeruli involved and less than 50% of a particular glomeruli area involved in this disease, known as segmental. So focal segmental glomerulonephritis is less than 50% involvement and less than 50% area of a particular glomeruli involvement. Diffuse segmental means all glomeruli, but in each glomeruli less than 50% involvement. Focal global means less than 50% glomerular involvement, but when the particular involved glomeruli having a whole segment involved. Okay. So basically these are nephritic syndrome. আগেরটা nephrotic syndrome, আগেরটা. Okay, basically these are general features of glomerulonephritis.
First is what is meant by chelation. Okay, chelation describes a particular way that ions and molecules bind metal ions. Okay, so what is chelation? Chelation describes a particular way that ions and molecules bind metal ions. So according to the international organization IUPAC, the formation or presence of two or more separate coordinate bonds between a multiple bonded ligand and a central atom, that is called chelation. I can show you a picture. So usually these ligands are organic compounds and are called chelants, chelators, chelating agents or sequestering agents. So you see, chelating agents, they are mainly used today in poisoning, in the treatment of poisoning. That is chelating agents main purpose right now. So chelation therapy, administration of the chelating agents to remove heavy metal ions from body. Okay, so who are prone to heavy metal poisoning? For example, a worker in a lead factory, okay, a miner in an area known for arsenic abundance. Okay, so arsenic poisoning, lead poisoning, okay, mercury poisoning, copper poisoning, mainly chelating agents are used in these particular cases. So what happens? The injecting chelating agents in liquid form into the body, or it may be given by oral. Then that forms bonds with specific toxic metals like I said, arsenic, lead, etc. The toxic metals are then excreted from the tissue or organ of the body. Both chelating agent and toxic metals are simply excreted from the kidneys. So, what are the characteristics for an agent to be called a chelating agent? So, the chelate effect increases the higher the density of the ligand. Typical characteristics of an ideal chelating agent include, this comes as a question, okay, J, characteristics of a chelating agent. Okay, it is not properly written in your textbook. So, you can take a picture, okay, because these particular points are not, I don't know about KD Tripathi, but in Sharma and other textbooks, Srivastav, it is not properly written. Okay, I haven't seen KD Tripathi, so I can't tell. So, highly soluble in water, okay, because it will has to be excreted out by kidney. It is highly soluble in water. Coordination complexes formed are relatively non-toxic. So, the bond between lead or copper and the chelating agent, the new product must be non-toxic. Can traverse cell membranes, must cross the cell membrane. Resistant to biotransformation, okay, resistant to biotransformation and able to form complex metal ions at different pH conditions in the body. In terms of mode of action, chelating agents bind to metals and form coordination complexes which are released from tissues. The complexes then enter the bloodstream and are ultimately eliminated from the body, typically by renal excretion. Okay. So, chelating agent must be water soluble and it must form a complex with the ion, with the metal. It may be copper, it may be lead, it may be arsenic, but it must form a bond with the metal and the new product, the bond and the original metal, the new product must be non-toxic and must be able to be excreted out by the kidney. Okay. So, some chelating agents with their uses approved by the FDA, that is Food and Drug Administration of United States. We know it, call it US FDA. Take a picture of this. Okay. See, Dimercaprol, you must remember, we will ask questions like name some chelating agents, okay, and you have to tell at least Dimercaprol, that is previously called British anti-Lewisite, okay. Another is very important, Dimercaprol, another is penicillamine, okay, at least mention these two, okay. Other you may not tell, you may forget, but at least mention these two, that is Dimercaprol and penicillamine, okay, don't forget. Acha, Dimercaprol ki, in which cases it is given acute arsenic poisoning, acute mercury poisoning, lead poisoning and the original one Lewisite poisoning, for which it was actually developed as an antidote, okay. Bell, British anti-Lewisite. Now, it has been, problem was Dimercaprol was that, I am coming to that, it has lot of side effects, okay. So, it was subsequently modified with time and Dimercaprol was modified into DMSA, dimercaptosuccinic acid, which is again used in the same conditions. Arsenic poisoning, lead poisoning, mercury poisoning, but with reduced side effects. Okay. So, initially it was Dimercaprol or Bell and then it was converted to DMSA, that is dimercaptosuccinic acid. Okay. DMPS you may not remember. Okay. It is not that much important, not that much used. Which is currently used or previously was very much used is penicillamine. Penicillamine. It is mainly used in copper toxicity. We call it Wilson's disease. Okay. So Wilson's disease treatment is penicillamine. You can give it by oral tablet. Okay. Penicillamine. Occasionally adjunctive therapy in gold toxicity, arsenic toxicity, lead poisoning and rheumatoid arthritis. Okay. So penicillamine is also a DMARD. What is DMARD? Anti-rheumatic drugs. So penicillamine is also a DMARD. Okay. It is used in rheumatoid arthritis. It has been seen to reduce the inflammation mediated by T lymphocytes. Okay. T lymphocyte mediated inflammatory response, penicillamine blocks that. Many others mechanism of action is still there, but it is yet to be discovered. Okay. Next is we know EDTA. Huh? You know EDTA? Ethylene diamine tetraacetic acid. Huh? Kind of physiology te পড়িসনি EDTA? Right? So that is also used in lead poisoning. So you must remember what I am repeatedly telling. You may not answer all the chelating agents, but at least you should remember. You must tell Dimercaprol or Bal and penicillamine. Okay, that is must. So this is you can say this is the function of a chelating agent. So you see the metal ion, okay, and it is blocked by various hands of the chelating agent. Okay, so that is a chelate. Okay, and this is the chelate metal complex. Okay, and this chelate metal complex once formed, it must be able to be excreted out by the kidney. Okay, because if this complex is not excreted out by the kidney, then the entire function will becomes meaningless. Okay, so the complex must be formed with the metal ion and the chelate, and the complex must be able to be excreted out by the kidney. Okay, to have that characteristics, the complex must be water soluble. So EDTA chelation therapy is a treatment that involves repeated intravenous administration of a chemical solution of EDTA. Injected intravenously and once in bloodstream, EDTA traps lead and other metals, forming a compound that the body can get rid of in the urine. Very important. This process generally takes 1 to 3 hours. Okay? Is regarded by the body as a foreign substance. So the body eliminates the entire particle, the heavy particle coated with EDTA. That's what I said. Okay, the complex formed with the metal must be able to be excreted out by the kidney. Coming to the taking all the questions. Has been used extensively in mainstream medical settings to remove the toxic metal lead from the human body. Acts as a powerful antioxidant to protect blood vessels from free radical. EDTA chelation therapy is approved by the US FDA as a treatment for lead and heavy metal poisoning. It is used to treat acute and chronic lead poisoning by pulling toxins from the bloodstream. Because EDTA cannot be given in the body without being a salt. Any drug like atropine, you have to add something with that. Like it must be atropine sulfate, right? So EDTA can be sodium EDTA. EDTA can be calcium EDTA. Sodium EDTA where you use? Can you tell? Yes, যখন আমরা কোনো পেশেন্টকে বলি যে CBC, complete blood count, you have to do. Okay, so the blood must not coagulate. To that we have to use a vial that is called purple vial. That cap is purple, and what that contains? It contains sodium EDTA. Okay, because otherwise EDTA it's an acid. It won't be viable. You have to convert it into a salt and give it. Acha, next is penicillamine. Penicillamine, very important. I said because it is in the WHO organization's list of essential medicines. You see, essential medicine is very favorite topic of our, right, pharmacology. So, so penicillamine was approved for medical use in the United States in 1970, and it is on the World Health Organization's list of essential medicines. Okay, so kothay kothay deowa jabe? Very important, penicillamine is a medication used for treatment of Wilson's disease, kidney stones who have high urine crystal levels, rheumatoid arthritis, and very heavy metal poisoning. Rheumatoid arthritis, generally in practice we don't give penicillamine. Okay, lot of other substitutes are there, we don't give penicillamine. So again you see what is the function of a chelating agent. You see, this is a penicillamine, okay, and it has bound with the copper, okay, and this total complex must be excreted out. Okay, so medical uses in Wilson's disease, a rare genetic disorder of copper metabolism. In Wilson's disease, a rare genetic disorder of copper metabolism, penicillamine treatment relies on its binding to accumulated copper and elimination through the urine. Clear? In cystinuria, a hereditary disorder in which high urine crystine levels lead to the formation of cystine stones, penicillamine binds with the cystine to yield a mixed disulfide which is more soluble than the cystine. More or less it is binding with the cystine and the complex is being excreted out by being water soluble. Penicillamine has been used to treat also scleroderma, but the cause is not known. Penicillamine can be used to treat rheumatoid arthritis as a disease modifying anti-rheumatic drug, that is DMARD. In what type of rheumatoid arthritis? In patients who have failed to respond to an adequate trial of conventional therapy. Okay, so what is the conventional therapy of rheumatoid arthritis? Anybody can tell? Rheumatoid arthritis e ki dibi? হ্যাঁ মেথোট্রিক্সের দিবি, ঠিক। What will be the dose? হ্যাঁ আচ্ছা বেশ, ঠিক আছে, মেথোট্রিক্সের দিবি once a week. Okay, you start it with 2.5 milligram once a week. That is the dose of methotrexate. Any other drug you can give in rheumatic arthritis? Base, any other drug? Very good, prednisolone, তাই না? So steroid you can give, তাই তো? আর কি বলছিস বল? Hydroxychloroquine, very good, very good. Can you give the patient directly hydroxychloroquine, or you have to tell something or make a test of something? কোনো ব্লাড টেস্ট করতে দিবি এই সিকিউ দেওয়ার আগে? খুব ভালো অ্যান্সার, অ্যাবসলিউটলি। Hydroxychloroquine you have to give, you can give. Methotrexate you can give. Prednisolone you can give, absolutely. Now the question is, can you give hydroxychloroquine right like that, or you have to tell the patient that come make this test and then if the result is negative we can give you HCQ. Hydroxychloroquine এর সাইড এফেক্ট কি? হ্যাঁ কি বললি? No, one of the side effects too are, that's not side effect. কোনো অ্যানিমিয়া হয়? not megaloblastic. hemolytic anemia. Okay, hemolytic anemia হয় তাহলে before giving hydroxychloroquine you have to tell the patient that you do a CVC, okay, and G6PD, because hydroxychloroquine is contraindicated in G6PD deficiency. Okay, so if the patient is G6PD deficient, it will cause hemolysis and further anemia. Okay, so a malaria positive case or a rheumatic arthritis case, before you give hydroxychloroquine, you tell do a G6PD and then come back. Okay, তোদের একটা প্রবলেম আমি আগেও বলেছি, তোদের কোনো ডিজিজ দিলে তোরা প্রথমেই একদম সুপার হাই লেভেলে ভাবতে শুরু করবি। দ্যাট ইজ নট দ্য ওয়ে। মেথোট্রিক্সেট নিশ্চয়ই দিবি, হাইড্রোক্সিক্লোরোকুইনও দিবি, কোনো প্রবলেম নেই, প্রেডনিসোলোনও দিবি, আর ডাইক্লোফেনাকটা দিবি না? ডাইক্লোফেনাক, হ্যাঁ, এনসেডটা তো দিতে হবে সবার আগে। পেশেন্টের কমপ্লেন কি হবে? পেইন ইন মাল্টিপল জয়েন্টস অ্যান্ড সোয়েলিং, এই তো। when there is pain you should must give the first thing diclofenac, and then you add a methotrexate once a week, and then you add prednisolone. Okay, good, but still answer is good, hydroxychloroquine, very good. আচ্ছা, পেনিসিলামিনের সাইড এফেক্ট কি কি? lot of side effects, rash, nausea, diarrhea, low white blood cell count, and other serious side effects include liver problems, obliterative bronchiolitis, and myasthenia gravis. Other possible less common adverse effects includes nephropathy, hepatotoxicity, glomerulonephritis, aplastic anemia, and lot of others are there. Mainly it may cause nausea, diarrhea, and low blood white cell count. Penicillamine. Acha, how does penicillin act in rheumatic arthritis? Okay, এটা একটা লাইনই জানা আছে, সেটা হচ্ছে it reduces the inflammatory process by blocking the actions of T lymphocyte. Okay, blocks the actions of T lymphocytes. Next হচ্ছে last one, that is Dimercaprol or BAL, British anti-leucide. Its use is arsenic, gold, bismuth, antimony, and mercury poison. Okay, mainly. Not very much used today. Okay, Dimercaprol যেটা ইউজ হয় সেটা হচ্ছে lead poisoning. That remember this much, it is mainly used in lead poisoning and arsenic poisoning, and it can be used in case of Wilson's disease if the patient is allergic to penicillamine. Okay, then you can give later on BAL was modified into DMSA, like I said. So Dimercaprol was converted to dimercaptosuccinic acid, which has having less side effects.